Good evening, everybody. I am Dr. Liaquat Ali Gori, Senior Professor and Head of Rheumatology at SP Medical College, Bikaner, Principal and Controller, Additional Charge Format at SP Medical College, Bikaner. I shall be presenting recent trends in management of osteoporosis. Osteoporosis is characterized by decreased bone strength. Sources estimate that 50 million people in India are osteoporotic or have a low bone mass. Prevalence in India is 42.5% in women and 24.6% in men above 50 years of age. Affects more than 10 million individuals in United States, but only a small proportion are diagnosed and treated. Worldwide, it is estimated that 1 in 3 women and above the age of 50 and 1 in 5 men will experience osteoporotic fractures. This is a diagram showing osteoporosis, normal femur and the osteoporosis, healthy bone and bone with the osteoporosis. Definition. Osteoporosis is defined as a reduction in the strength of bone that leads to an increased risk of bone fractures. WHO operationally defines osteoporosis as a bone density that falls 2.5 standard deviations below the mean for young healthy adults of the same age and race. Women with the highest risk of fractures are the ones most likely to benefit from osteoporosis drug therapy. Therefore, selection of patients based upon the fracture risk as determined by a combination of bone mineral density and clinical risk factors is desirable. Approach for the initiation of therapy is according to National Osteoporosis Foundation recommendations. These recommendations are widely accepted and clinical trials data support the use of bisphosphonates to prevent fracture in such individuals. Guidelines for pharmacological intervention in postmenopausal women and men equal to over 50 years of age. History of hip or vertebral fracture. T-score equal or less than -2.5 DEXA at the femoral neck or spine after appropriate evaluation to exclude secondary causes. T-score between -1 and -2.5 at the femoral neck or spine, and 10-year probability of hip fracture equal to more than 3% or a 10-year probability of any major osteoporosis related fracture equal to more than 20% based upon the WHO algorithm. This is a diagram showing epidemiology of vertebral hip and core fracture with age. It is a diagram showing osteoporosis is a fracture risk assessment. In 2008, a WHO task force introduced FRAX, Fracture Risk Assessment Tool, which estimates the 10-year probability of hip fracture or a major osteoporotic fractures combined hip, spine, shoulder, wrist for an untreated patient using femoral neck BMD and easily obtainable clinical risk factors for fracture. Fracture risk assessment tool, various factors to see. There is the age of the patient, sex, weight, height, then previous fracture, parent related hip, then current smoking, glucocorticoids, rheumatoid arthritis, secondary osteoporosis, alcohol 3 or more units, femoral risk, BMD. These are important factors for FRAX estimation. Clinical application of fracture risk assessment. Use of country-specific fracture data, life expectancy data, and economic assumptions with FRAX allows the clinicians to identify patients likely to benefit from therapy better than qualitative methods. Treatment guidelines based upon FRAX are likely to lead to more drug treatment in older patients with slightly low T-scores and high-risk fracture. Less use of drugs to treat younger patients with low T-scores and low risk of fractures. Clinical risk factor for fracture, advancing age, previous fracture, glucocorticoid therapy, parental history of hip fracture, low body weight, current cigarette smoking, excessive alcohol consumption, rheumatoid arthritis, secondary osteoporosis due to hypogonadism, malabsorption, chronic liver disease, or premature menopause. Drugs associated with increased risk of osteoporosis in adults, glucocorticoids, cyclosporine, cytotoxic drugs, anticonvulsants, aromatase inhibitors, SSRIs, excessive thyroxine, aluminium, gonadotropin releasing hormone agonist, heparin, lithium, protein pump inhibitors, thiazolidine ions, androgen deprivation therapies. Dual energy absorptimetry is a DEXA, only technology that can be used for diagnostic classification. The most useful technology for monitoring serial BMD changes to monitor the response of therapy. DEXA measures bone mineral content in grams and bone area in square centimeter, then calculates the area BMD in gram per square centimeter. This is a machine showing how to measure this bone density. These are the various measures by which we can see normal, osteoporosis and osteopenia. Categories same, showing normal bone density, then in between is osteopenia, and low is the osteoporosis. Choice of therapy. In the absence of high quality head-to-head drug comparison trials to determine the relative efficacy of individual drugs, choice of therapy should be based upon efficacy, safety, cost, convenience, and other patient-related factors. All patients treated with pharmacotherapy should have normal serum calcium and 2,5-hydroxyvitamin levels prior to starting therapy. Patients should receive supplemental calcium and vitamin D if dietary intake is inadequate. Bisphosphonates, mode of action. Bisphosphonates are structurally related to pyrophosphates compounds that are incorporated in the bone matrix. These drugs specifically impair the osteoclast function and number by inducing apoptosis. Mechanism of bisphosphonate inhibition of osteoclastic activity. Next. List of bisphosphonates: alendronate, risedronate, ibendronate, zoledronic acid, etidronate, telludronate, and pamidronate. Alendronate, risedronate, and ibendronate and zoledronic acids are approved for treatment and prevention of postmenopausal osteoporosis. Alendronate, risedronate, and zoledronic acid are also approved for the treatment of steroid-induced osteoporosis and treatment of osteoporosis in men. Risedronate and zoledronic acid are approved for prevention of steroid-induced osteoporosis. Alendronate, it decreases bone turnover and increases the bone mass in spine by up to 8% and 6% in the hip. Daily alendronate treatment 5 mg per kg for 2 years and 10 mg per day for 9 months afterward. Reduces vertebral fracture risk by about 50% and multiple vertebral risk fractures by up to 90% and hip fractures by up to 50%. Once weekly 70 mg alendronate therapy is preferred because of lesser GIT side effects and ease of administration. Alendronate should be taken with full glass of water before breakfast after an overnight fast. Because of risk of esophageal irritation, alendronate should not be given in patients with strictures or inadequate emptying of esophagus. It is recommended that patients remain upright, standing or sitting for at least 30 minutes after taking the medication, and fluids other than water and food should be avoided for this duration. Risedronate 40 to 50% reduction in the vertebral fracture risk over 3 years, 40% reduction in non-spine fractures, 40% reduction in hip fracture risk in women in 70s of age. 35 mg of risedronate administered once weekly is therapeutically equivalent to 5 mg per day. Patients should take risedronate with full glass of water and should not lie down for 30 minutes. Ibendronate 2.5 mg per day has been shown in clinical trials to reduce vertebral fracture risk by 40%, but with no oral effect on non-vertebral fractures. In clinical trials, doses of 150 mg per month or 3 mg every 3 months IV had greater effects on turnover and bone mass than did 2.5 mg per day. Zoledronic acid. Potent bisphosphonate with unique administration regime 5 mg by 15 minutes IV infusion annually. 70% reduction in risk of vertebral fractures, 25% reduction in risk of non-vertebral fractures, 40% reduction in risk of hip fractures, 35% reduction in risk of recurrent fracture, to 28% reduction in mortality. The same is shown by the diagram, graphic representation. Same adverse effects of bisphosphonates: musculoskeletal and joint pain, renal toxicity contraindicated in patients with GFR less than 30 to 35 ml per minute, hypocalcemia, osteonecrosis of jaw, atypical femoral fracture, oral risk is low. SERMs, selective estrogen receptor modulator. These are currently in post-menopausal women, raloxifene and tamoxifen. Raloxifene has effects on bone turnover and bone mass and has estrogenic effect on skeleton. Reduces the occurrence of vertebral fracture by 30 to 50%. It is FDA approved for the treatment and prevention of osteoporosis. In contrast to tamoxifen, raloxifene is not associated with the increase in risk of uterine cancer. Raloxifene increases the occurrence of hot flashes but reduces serum total and low bone density lipoprotein cholesterol. Raloxifene with positive effect on reduction in invasive breast cancer occurrence and vertebral fractures has become a useful agent for the treatment of younger asymptomatic post-menopausal women. Same is shown. This is the effect of denosumab on new vertebral fractures. Calcitonin, polypeptide hormone produced by the thyroid gland. Calcitonin preparations are approved by FDA for osteoporosis in women more than 5 years post-menopause, Paget's disease, hypercalcemia. Calcitonin suppresses the osteoclast activity by direct action on the osteoclast calcitonin receptor. A nasal spray containing calcitonin 200 intranasal per day is available for the treatment of osteoporosis in post-menopausal women. Recently, concerns have been raised regarding the cancer risk with calcitonin use. Denosumab, a novel agent that is given twice yearly by subcutaneous administration in a post-menopausal women, increases the BMD in the spine, hip and forearm. It is fully human monoclonal to rank L and inhibits its ability to initiate formation of mature osteoclasts. Reduces vertebral fracture by 70%, reduces hip fracture by 40%, reduces non-vertebral fracture by 20%. It is the mechanism of action of denosumab. Denosumab reduces the risk of fractures in women on aromatase inhibitors and also reduces the risk of breast cancer recurrence significantly. In a study of men with prostate cancer, denosumab increased the bone mass and reduced vertebral fractures. FDA approved for treatment of post-menopausal women with osteoporosis fracture risk. Side effects of denosumab: increase the risk of osteonecrosis of jaw, atypical femur fractures, hypersensitivity reactions, hypocalcemia, dermatitis, rash, eczema. When denosumab is discontinued, there is a rebound increase in the bone turnover and therefore rapid increase in the risk of fractures, particularly vertebral fractures. Anabolic agents, parathyroid hormone analogues, exerts anabolic effect on the bone and maintains trabeculae bone mass and reduce fracture occurrence. Teriparatide (PTH), in a pivotal study, a dose of 20 microgram daily by subcutaneous injection for a median 19 months duration had reduced vertebral fractures by 65% and non-vertebral fractures by 40 to 50%. In women with painful acute osteoporotic vertebral fractures, teriparatide reduced subsequent fractures by about 50% compared with the risodinate. There was no difference in the non-vertebral fracture outcome between the two medications. Side effects: muscle pain, weakness, dizziness, headache, and nausea rarely can cause osteosarcoma. These are showing the effect of teriparatide on the risk of new vertebral fractures. Abaloparatide. Abaloparatide is a synthetic analog of human PTH related peptide and binds PTH type 1 receptor. In the phases 3 abaloparatide comparator trial in vertebral endpoints study following observations were made. At 18 months, the spine BMD increased by 11.2%, new vertebral fractures incidence were reduced by 86%, non-vertebral fractures reduced by 43%. Effect of parathyroid treatment on bone microarchitecture. Romosozumab. It is a humanized antibody that increases the osteocyte production of sclerostin, resulting in increase in bone formation and decline in bone resorption. In the pivotal trial of FRAME, the BMD increased over 13% in spine and 70% in hip in 1 year with the romosozumab. Fracture risk of non-vertebral and vertebral fractures were reduced by 36%. Odanacanatib, a cathepsin K inhibitor, inhibits the osteoclast collagenase enzyme, preventing bone resorption. In a very large controlled trial, 17,000 post-menopause women with osteoporosis, bone mass increased in spine and hip and reduced vertebral, hip and all non-vertebral fractures. Unfortunately, risk of stroke was high and development of this agent was aborted in 2016. Therefore, it remains an unapproved pharmacological therapy. Sodium fluoride was tested in 2 large clinical trials in the late 1980s. Although BMD increased substantially, fracture risk was not reduced and was in fact increased in non-vertebral sites. Therefore, fluoride is no longer considered a viable option for osteoporosis treatment. Strontium ranelate is approved in Europe. It increases the bone mass throughout the skeleton. The drug reduces the risk of vertebral fractures by 37%, reduces the risk of non-vertebral fractures by 14%. In 2014, use of strontium was restricted because it increases the risk of cardiovascular disease and severe skin reactions. Non-pharmacological approaches. Protective pads worn around the outer thigh, which covers the trochanteric region of hip, can prevent hip fractures in elderly. Take-home message. Alendronate, risperidone, and zoledronic acid are approved for the treatment of post-menopause osteoporosis, steroid-induced osteoporosis, osteoporosis in men. Riloxifene reduces the occurrence of vertebral fractures by 30 to 50% and is approved for the treatment and prevention of osteoporosis. Teriparatide reduces the risk of fractures by 50% in women with painful acute osteoporotic vertebral fractures. Calcitonin tetrations are approved by FDA for osteoporosis in women more than 5 years post-menopause, Paget's disease, and hypercalcemia. Thank you for your kind attention.